everyone. Thank you for joining today's Web Interface support call. This presentation will be followed by a Q&A session where attendees will have an opportunity to ask questions via phone and the support call questions box. And CMS subject matter experts will address as many questions as time allows. Also to note, a recording of today's slide deck from today's call will be posted to the QPP webinar library within the next 2 weeks. Now I will turn it over to Sandra Adams-Slaughter at CMS to begin. Sandra?
Thank you, Haley. Welcome, everyone, and thank you for joining us today as ACOs prepare for quality reporting. I'm Sandra Adams-Slaughter from CMS. Joining me on the call today are other CMS experts and contractors who will share helpful information on CMS Web Interface quality reporting and answer your questions following today's presentation. Today's call will only focus on 2023 CMS Web Interface quality reporting. You can contact the Quality Payment Program Service Center with any of your questions regarding cost, promoting interoperability, improvement activities, MIPS, or quality reporting in general. Today's slide deck recording and transcript will be available on the QPP webinar library within the next 2 weeks. Next slide, please. This is a disclaimer slide about the presentation. Information in this presentation is current at the time it is published, but I urge you to please be sure that you're using the source documents and links that are provided throughout the presentation. Next slide, please. And next slide. The CMS Web Interface will close at 8 p.m. Eastern Time on April 1st, 2024. Your submission will automatically be accepted at submission close. As a reminder, the CMS Web Interface is accessible using the sign-in link that can be found on the Quality Program Payment Program website. Next slide, please. And there's a sign-in link. Next slide, please. The CMS Web Interface Application Programming Interface is available for testing all year in the developer preview environment. Please review the links listed here for more information. Next slide, please. This slide is about submitting requests to skip patients. This slide reviews information about submitting a CMS approved reason. Please note it isn't necessary to request an other CMS approved reason if there's an applicable denominator exclusion, if there's an applicable denominator exception, if the patient is not qualified for the sample, because the patient is deceased in hospice or moved out of the country, or didn't have fee-for-service Medicare as their primary payer, and or if the pre-populated demographic information isn't accurate. Next slide, please. And this is a reminder that to please submit your request for another CMS approved reason early. Requests submitted after Monday, March 25th may not be processed prior to close of the submission period. And so please submit your request as soon as possible. For more information on how to submit an other CMS approved reason request, please review page 45 of the CMS 2023 CMS Web Interface User Guide. Next slide, please. And now I will hand it over to Katie Moore to review measure level exclusions, exceptions, and frequently asked measure questions. Thank you.
Thank you, Sandra. Now we'll review the exclusions and exceptions. Next slide, please. So as an overview, there are two options that will remove a patient either from the measure or the measure's performance calculation. Measure owners may specify that a patient should be excluded from the denominator of a particular measure, which would be a denominator exclusion, or from the calculation of performance for the measure, which is a denominator exception. For measures where the measure owner has identified an appropriate denominator exclusion and/or exception category, it will be specified within the measure specification. An option is available in the CMS Web Interface that allows Shared Savings Program ACOs to indicate that a given patient meets the exclusion or exception criteria for a measure. A denominator exclusion are patients who should be removed from the measure population and denominator before determining whether the numerator criteria are met. If a patient meets the denominator exclusion criteria, they must be removed from the measure population. This patient will be replaced with the next consecutive patient sampled for the measure. A denominator exception is when a patient is eligible for the denominator, but the measure specifications define circumstances in which a patient may be appropriately deemed as a denominator exception. There are three general categories of allowable reasons: medical, patient, and system. A denominator exception removes a patient from the performance denominator only if the numerator criteria aren't met as defined by the exception. This allows for exercise of clinical judgment by the MIPS-eligible clinician. When a denominator exception is selected, the patient is considered completed for reporting. Next slide, please. Okay, now we will review some frequently asked measure questions. Next slide, please. The first measure that we'll cover is DM2, diabetes hemoglobin A1C poor control, greater than 9%. The intent of this measure is for patients 18 to 75 years of age with diabetes that have a most recent hemoglobin A1C greater than 9% during the measurement period. Documentation of the most recent HbA1c result may be completed during a telehealth encounter. Next slide, please. Okay, now we'll review some of the frequently asked questions. Number one is for the DM2 measure, will patients only be included in the measure if they have a diagnosis of diabetes during the measurement year, or will they be included if they have poor diagnosis, but no prior diagnosis, but no diagnosis during the measurement year? The response is that a patient must have an active diagnosis of diabetes during the measurement period or an active diagnosis of diabetes during the year prior to be included in the measure. Question 2 is for DM2, do I use the date the blood was drawn or the date of the lab results? The response is that it's appropriate to use the following priority ranking for the numerator of the 2023 DM2 measure: lab report draw date, lab report date, flow sheet documentation, practitioner notes, and lastly, other documentation. Question 3, will HbA1c results from any setting be acceptable for the numerator for the 2023 reporting period? The answer is yes. The measure doesn't limit the numerator to a specific setting. Next slide, please. The next question is, are continuous glucose monitoring system results acceptable for the numerator? The answer is no. The 2023 DM2 measure doesn't include CGM results as a way to meet performance for the measure. Report the most recent HbA1c value documented in the medical record. Documentation must have a distinct numeric HbA1c result and the date the blood was drawn. Number 6, some patients have at-home HbA1c testing kits, meaning the patient is checking their lab values at home. Is this allowed for the 2023 DM2 measure? The answer is no. don't include HbA1c levels reported by the patient. The 2023 DM2 measure doesn't allow patient-reported HbA1c values to meet the numerator. Question 7. The 2023 DM2 measure specification no longer contains the guidance that only type 1 or type 2 diabetes should be included in the denominator. Are patients with a diagnosis of secondary diabetes eligible for the denominator? The answer is yes. The 2023 DM2 measure specification was updated to align with the intent of the measure, which is to ensure HbA1c control in all patients with any diagnosis of diabetes. Therefore, guidance to only include type 1 or type 2 diabetes was removed. Question 8 is, how can documentation of the most recent HbA1c result be completed during a telehealth encounter if patient-reported HbA1c levels aren't allowed? The response is that the measure specification doesn't provide detailed information on what can be obtained during a telehealth encounter regarding the HbA1c value due to the variety of possible interactions during a telehealth visit. This allows clinicians to determine the workflow that works while following and maintaining the intent of the measure. For example, a patient may have a lab report with their most recent HbA1c value, and this lab report could be sent to or shared with the clinician by the patient during the telehealth encounter. For example, using this example, the medical record would include documentation of an HbA1c lab value during the telehealth encounter, not a patient-reported value without a documented medical reference. Next slide, please. Okay, now we will review Pref 13. The intent of this measure is for patients who are considered at high risk of cardiovascular events to be prescribed or taking statin therapy during the measurement period. Documentation of statin therapy prescribed or being taken during the measurement period can be completed during a telehealth encounter. Next slide, please. Okay, now we'll review frequently asked questions for Pref 13. Number 1 is documentation of hypercholesterolemia alone sufficient to confirm a diagnosis of familial hypercholesterolemia for population 2 in the 2023 Pref 13 measure? The answer is no. If hypercholesterolemia alone is present and there's no other documentation to support familial hypercholesterolemia, it wouldn't be appropriate to confirm the patient in the denominator of population 2. If hypercholesterolemia is present in the medical record along with supporting documentation of familial hypercholesterolemia, it would be appropriate to confirm the patient in the denominator of population 2. Question 2. For population 2, is it acceptable to use any variation of the ICD-10 code E78 to confirm the diagnosis of familial hypercholesteremia? The response is, since the measure requires confirmation of a diagnosis of familial hypercholesterolemia, other cholesterol-related diagnoses aren't appropriate. ICD-10 diagnosis code E78.01 familial hypercholesterolemia is present in the Pref 13 coding document denominator codes tab, along with other coding that may be used to identify hypercholesterolemia. Other variations of the E78 code aren't specific to familial hypercholesterolemia. If you find other medical record documentation supporting the diagnosis of familial hypercholesterolemia, then the diagnosis would be confirmed. Question 3. When does the denominator exception, for example, muscle symptoms or an allergy to statin medication, need to be documented in the medical record? Your medical record documentation should support that the denominator exception is active during the performance period and should support that a statin wasn't prescribed due to an applicable denominator exception. Next slide, please. Question 4. If the clinician documents a patient allergy or statin-associated muscle symptoms to one particular statin, is it acceptable to choose the denominator exception medical reason, or does the clinician need to say allergic/statin-associated muscle symptoms to statins for the 2023 CMS Web Interface Pref 13 measure? The response is a listing of drugs for the denominator exception is on the denominator exception drug codes tab of the 2023 Prev 13 coding document. For mapping from the EHR, when an accepted drug allergy is found, look for the drug classification with a YC, yes conditional, in the drug X column of the denominator exception drug codes tab. These drugs may be used as a denominator exception if present in the patient's record, accompanied by an appropriate conditional reason why the patient isn't taking the drug, i.e. statin-associated muscle symptoms or an allergy to statin medication. What is considered a medical reason for not taking statin therapy? The 2023 Prev 13 measure specification isn't prescriptive as to what qualifies as a medical reason for not prescribing statin therapy. A clinician may use their discretion as to what constitutes a medical reason. However, there must be documentation supporting why the patient wasn't prescribed statin therapy. Next slide, please. Okay, now I'll hand things back to Sandra to cover resources and where to go for help.
Thank you, Katie. These next few slides will outline the available CMS Web Interface resources. Next slide, please. Please note that 2023 submission resources are available on the Quality Payment Program Resource Library. We encourage you to review these documents if you have questions on quality requirements and measures. Next slide, please. The recording, slides, and transcripts from the first two CMS Web Interface support calls are now available on the Quality Payment Program Resource Library. Next slide, please. If you need additional assistance, please refer to the contact information listed on this slide. And now I'll hand things over to Haley to begin the question and answer session.
Thanks, Sandra. We can go to the next slide. We're now going to start the Q&A portion of the webinar. You can ask questions via the Q&A box or through the webinar audio. To ask a question via the webinar audio, please raise your hand and we will unmute your line so that you can speak. To submit a question anonymously via the Q&A box, please click Send Anonymously. Otherwise, all attendees will be able to view your question. To start us off, we have a few questions in the queue. The first question is for Jamie, and the question reads, for each TN2, the most recent blood pressure, 173/90 urgent care visit due to fall shoulder dislocation pain, patient was sent to the ER. Can we take the next most recent blood pressure in 2023 due to circumstances of the urgent care visit just described? Jamie?
Yep. Hi, good afternoon. Thanks so much for this question. We conferred quickly behind the scenes, taking a look at the detail in this question, and we believe that it would be best if you requested an other CMS reason. We'll evaluate the situation and then be able to reply back to you. Just be sure that the explanation is robust. If not, we'll just have to reach out for clarification, but please submit an other CMS reason for consideration. Thanks.
Thank you, Jamie. Our next question is for Deb, and Deb, the question is asking for some clarification. On the last call, it was reported that we could use a frailty code as a denominator exclusion if it was documented in the patient's medical record during the measurement period, even if the code was not filed on a claim. For example, if the medical record supports the finding of OSA on CPAP in the PMH, but the condition is not addressed during the visit, nor is a diagnosis submitted on a claim, can we count this as a frailty condition for consideration to exclude the patient? Deb, are you there? I see your mic is unmuted, but we cannot hear you.
Hey, Hallie, if we can circle back to this question, that would be great. I think we might just need another minute or two if we can't get Deb back to give an appropriate answer. So we can come back to this one. Thank you.
Okay, thank you, Katie. Actually, Katie, the next question's for you. And the question reads, for Prev 13, if the provider does not prescribe a statin with the reason of patient's advanced age, can that count for a medical reason exception?
So this is sort of a nuanced question. So my recommendation here would be to either submit a ticket to qpp@cms.hhs.gov. Another option would be to submit a skip request with detailed information outlining perhaps the patient's age and other justification for not prescribing a statin, so that can be evaluated on a case-by-case basis. Thank you.
Thanks, Katie. The next question we have is for Carrie. And Carrie, that question reads, we accidentally changed the cell of a rank number, and when we corrected it, Excel is no longer sorting the patient. Does this mean there will be a problem with uploading this data to the QPP?
Good morning, good afternoon. The good news is no, there will not be a problem when you go to upload. When you make a change like that, the system won't recognize that change as you make your upload into the web interface. And the beneficiary will remain ranked as they were prior. And your any other changes you made to that beneficiary will be run into the system appropriately.
Thank you, Carrie.
Hey,
Next,
Hallie. This is
Oh.
Deb. Can you hear me?
Yes, Deb, we can hear you.
Well, how about that? I am so sorry. I don't know what was going on with my headset. Would you like me to answer that DM2 question, or was someone else from the team able to do that?
If you would be able to answer it, that would be fantastic. Let me repeat the question just so that everyone can hear it. So the question asks, please clarify, on the last call, it was reported that we could use a frailty code as a denominator exclusion if it was documented in the patient's medical record during the measurement period, even if the code was not filed on a claim. For example, if the medical record supports the finding of OSA and CPAP in the PMH, but the condition is not addressed during the visit, nor is a diagnosis submitted on a claim, can we count this as a frailty condition for consideration to exclude the patient?
And this is Deb. Yes, you can. As far as clarification from last week, that response was accurate. As long as your medical record supports the requirements set by the measure specifications, you would be okay. So as long as your medical record documentation supports the frailty, please feel free to use that. Thank you.
Thank you, Deb. We also have another question for you about Prev 10. And that question reads, for a tobacco user, if the provider states in the note, advised to quit smoking in regards to tobacco dependence, does that count for cessation intervention?
And thank you for that Prev 10 question. Unfortunately, I cannot give you a direct response because we are not able to specifically speak to what you have documented in your medical records and whether or not that is sufficient. However, I can point you to page 6 of the posted Prev 10 measure specification, where tobacco cessation intervention does have a definition, which includes brief counseling, 3 minutes or less. So I would say as long as your medical record documentation supports that definition of tobacco cessation intervention, that would be acceptable. Thank you.
All right, thank you, Deb. We do have a couple other questions for you. The first is just a quick confirmation that a pre-populated date for the first flu season August 1st, 2022 to February 28th, 2023 needs no action or no encounter on our part.
So just to clarify, and if I'm not quite responding to the question, please feel free to kind of update your question within the Q&A and I will come back to it. However, if you have no encounter is what is identified, then that is indicative of the fact that no encounter was identified for that patient for that flu season. So there is nothing needed on your part. Thank you.
Thank you, Deb. Our next question is for Jamie. Jamie, the question reads, for DM2 diabetes, hemoglobin A1C measure frequently asked question number 2. If the patient has a hemoglobin A1C with results during the measurement period below 9, but has a hemoglobin A1C order placed at the end of the measurement period, but no results from that order, which one would be counted?
Hi, thanks so much for this question. We did a quick crosswalk between what was in that frequently asked question document and the specification. And I think just to clarify what's in the FAQ document is the expectation that the most recent lab value results, whatever is documented within your medical record, is what's used to suffice for moving through that web interface tool and reporting. So what I would guide is that within the measure specification itself, and let me just verify a page number here, page 10, if you look underneath the numerator submission, it's going to walk you through how you would approach entering this specific scenario into the web interface tool. And on the very last section, I wish I could show you, but it does say, like, if the patient, like the responses could be if the patient did not have one or more hemoglobin A1C tests documented or the results aren't found, that you would just enter that as a 0 value. So again, please reach out if you need further clarification or submit a ServiceNow help desk ticket and we can help you through. But that would be the response. Use that most recent finding in your medical record.
Thank you, Jamie. Deb, we have some additional questions for you. The next question is, can you confirm that changing a patient's demographics in QPP is not a permanent fix and that the beneficiary will need to contact Medicare to update?
So I can confirm that changing the patient's demographics in the QPP is not a permanent fix. There may be some additional information others on the phone want to provide, but that information within the web interface will not permanently fix any patient demographic changes.
Fantastic. Thank you, Deb. Just as a reminder, you are still able to submit questions via the Q&A box, or you can use the raised hand feature to answer a question live over the phone. However, moving along, Deb, we have another question for you about PREV 7. And that question reads, for PREV 7, how is the performance rate calculated? Does it include both flu seasons, even if patients are sampled into both?
So I'm going to go over just the general PREV 7 performance calculation. And if this does not address the question that you're asking, please restate what you want in the Q&A. If a patient is sampled into both flu seasons and the vaccine was provided for both flu seasons, that's obviously performance met. If the patient has been sampled into both flu seasons and you have a denominator exception for one flu season and a vaccine was administered for the other, that is also a performance met. If you have a patient that has been sampled into both flu seasons and both medical record documentations for the flu seasons indicate there's a relevant denominator exception, the patient would be a denominator exception. The one instance where if you have a patient in both flu seasons and during one flu season you have documentation of vaccine received and the other flu season there is documentation of no vaccine received and no denominator exception, that would be considered a performance not met. If you have a patient that is sampled into only one flu season, then your performance is based on that single flu season. Thank you.
Thanks, Deb. The next question for you reads, to verify, we do not need to submit a ticket for influenza no encounter entries.
That is correct. If you have a no encounter, there would be no need to submit a ticket. That basically is just identifying the fact that the patient was not identified during the sampling process as having an encounter for them to be sampled into that flu season for that particular patient. I hope that makes sense, but no, there is the simple answer is there is no need to submit a ticket if you have no encounter populated for a specific flu season for a patient.
Thank you, Deb. Our next question is for Katie. And Katie, that question asks, can members that are in a skilled nursing facility for all of 2023 be excluded?
Hi, so I just wanted to clarify, there is no overarching exclusion for patients that are in a skilled nursing facility for all measures. For the measures that contain frailty and advanced illness exclusions, we may be able to take a closer look at that, what that would mean in terms of the 90 consecutive days during the measurement period. However, we recommend submitting a help desk ticket so that we can research that a bit further. But I just wanted to clarify that there's no program level exclusion for patients in a skilled nursing facility. Thank you.
Thanks, Katie. We have a couple more questions for Deb in the chat. Deb, the first question for you asks, can you please review Prov 7 and why we're finding that the immunization has occurred and is in the medical record, but column BQ, but states no encounter and that cannot be changed?
So the only thing I can clarify here that has been provided on previous support calls is that no encounter cannot be changed. And please, someone else on this call, let clarify. But if you do change it, you will get an error. And so when we say you can't change it, that is just indicative of the fact that it should not be changed. It is the same as if we had, I'm going to use a different measure. So Prov 5, the breast cancer screening, if you found evidence that a patient had a mammography, but that patient wasn't included in your sample, you would not be able to add them. And so this is the same thing for Prov 7. It just happens to be that we're dealing with 2 flu seasons. So if you have no encounter for one of the 2 flu seasons, that is not something that you should be changing. If you do, you will receive an error. Thank you.
Thank you, Deb. Our next question is also for you, and it's asking about Prov 10. It is noted that in the visit, the patient declined tobacco counseling, but printed education was provided to the patient. Does this count?
And this does not count. Again, on page 6 of the posted specification, the counseling has to be 3 minutes or less, but also included within that definition is other concepts such as written self-help materials are not included in the Prov 10 coding and do not qualify for the numerator. So patient refusal of the tobacco cessation is not part of the measure specification, and there is included within the definition of the tobacco cessation that printed materials do not meet numerator. Thank you.
Thanks, Deb. Our next question is for Jamie, and the question asks, specifically for Prov 10, is it necessary for a patient to be screened for all forms of tobacco use? Would there need to be separate results for smoking, smokeless, or vaping?
Hi, the measures requirement here is only that any tobacco screening would suffice, and there is no need to separate out those results. The measure only requires that if there is a positive assessment for use of tobacco, that cessation would be then performed for the patient. That's it. Thanks.
Thanks, Jamie. Just another reminder that you are still able to ask questions either by raising your hand and we'll unmute your line for you to ask your question over the phone, or if you would like to pop your question into the Q&A box, we will have one of the subject matter experts answer your question by reading it out loud. You can also click Ask Anonymously if you would not like your name associated with the question. That being said, we have a couple more questions in our Q&A queue. The first one is for Deb, and the question asks, for influenza guidance, states influenza immunization during the flu season or report of previous receipt may or may not be completed during a telehealth encounter. What does this actually mean? How do you apply?
So what this basically means is if your medical record documentation indicates that the patient received a flu vaccine and that happened to have been documented during a telehealth encounter, this would be acceptable. Obviously, the vaccine itself cannot be administered during a telehealth encounter, but the documentation, if it occurred during a telehealth encounter, would be acceptable. Thank you.
Thanks, Deb. We have another question for you about flu. If it says no encounter for flu, but our records show there was an encounter with a flu vaccine, can the no encounter be overwritten?
And the answer to this is no, that cannot be overwritten. Thank you.
Thanks, Deb. Our next question is for Katie. Katie, the question asks, in MH1, if the depression diagnosis was resolved in the patient's record in 2023, would they still qualify for the measure?
Hi, so if the patient is denominator eligible, you would still want to report that the patient reached remission, making sure that it was within the measure assessment window, which is, or the measure assessment period, which is that the 14 months, the 12 months plus or minus 60 days in length for that follow-up PHQ-9. So the intent of the measure is for that PHQ-9 to be less than 5 and the patient has reached remission. So again, just to double check that it's within the appropriate window for the measure assessment period. Thank you.
Thanks, Katie. We have another question for you. For PREV-12 screening for depression and follow-up plan, if the patient has a current depression medication on their med list, does this count for the follow-up piece?
The medication alone would not count as a follow-up. There would need to be language indicating that the patient perhaps was continuing the medication as part of their follow-up plan. There needs to be some connection between the positive depression screening and the medication to indicate that that is part of their follow-up plan due to a positive depression screen. Thank you.
Thanks, Katie. Our next question is for Deb. Deb, the question's asking, is vaping part of tobacco screening starting this year?
And yes, vaping is included. Again, you can look at and reference page 6 of the posted measure specification. Vaping is included. Thank you.
Thanks, Deb. Our next question is for Prince. Prince, the question asks, if we extract data for all web interface beneficiaries, do we only have to submit all data extracted, or can we submit for only the required amount?
Hi. All ACOs, regardless of size, are required to completely and accurately report on a minimum of 248 consecutively ranked and confirmed Medicare patients for each measure. However, if the pool of eligible sampled patients is less than 248, then an ACO is required to report on all sampled patients. Thank you.
Thanks, Prince. Our next question is for Carrie. The question asks, for flu vaccine, we did upload a file that did override what was pre-populated into the flu vaccine. We have deleted the data in QPP and corrected back to exactly how the flu vaccines were pre-populated. It still shows error after several tries to delete the data and then enter it again. But the errors are still there. How do we get rid of the errors?
Good morning, good afternoon, Carrie Barrows. So it sounds like what you did was you downloaded the Excel file, you maybe copy and pasted in and overrode the no encounter values for Prev 7. And you then uploaded the file and then noticed that you had a whole slew of Excel errors due to not being able to actually overwrite the no encounter value in the actual web interface application. And then you tried to correct those in the web interface application proper. And there should not have been a way to correct them in the web interface application. You would need to correct them in the Excel file and then upload the Excel file again. And if I've got that wrong, please feel free to add information in the question and answer, and I'll respond from there.
Thank you, Carrie. Just another reminder that you can use the raise hand function to ask a question over the phone, and we will unmute your line. Or feel free to type your question into the question and answer box at the bottom of your screen, and we will answer it for you. That being said, Deb, we do have another question for you. And the question's asking, can you please repeat the calculations for Prev 7? That is the different combinations of possibilities for flu season 1 and 2. Deb?
Absolutely. So this is just if you happen to have a patient that has been sampled into both flu seasons. If a patient has been sampled into both flu seasons and the vaccine has been provided for both flu seasons, that is a performance met. If you have a patient sampled into both flu seasons and there is a vaccine for one flu season and documentation of a denominator exception for another flu season, that is a performance met. If you have the patient sampled into both flu seasons and 2 denominator exceptions, it would be considered a denominator exception. If you have a patient that has been sampled into both flu seasons, documentation of a vaccine in one flu season, and no documentation of a denominator exception or the vaccine for the other flu season, that would be a performance not met. Thank you.
Thanks, Deb. We had a couple other questions come in. Our next question is for Carrie, and the question asks, for flu vaccine errors in the portal due to our overwriting the data given by CMS, what is the impact? Any negative impact for these errors our system overwrote?
So if it's a true Excel error for attempting to change the no encounter value, there is no negative impact if you just disregard or ignore those errors.
Thanks, Carrie. And I see we have a question on the line from Alex. Alex, we have unmuted your line if you would like to unmute yourself.
Hey, can you hear me okay?
Yes.
Hey, good afternoon. I have a question regarding the view on the QPP portal. So there are view progress view on those measures, but it only gives me the consecutive patients that we completed. So for example, there are we reported 500, 200 patients, but we only it's only maybe we're missing the number 4 ranked on that measure, so it only gives the 3 numerator and denominator. But on the reporting data page, if we select that specific measure, it gives us all the green bars that's showing us there are completed patients that they're just not on the consecutive. So there are gray bars shows we did not complete those, and then all the other following those gray bars. So is that the intent of that progress tab and the measure tab? It shows different progress.
This is Carrie. Good morning, good afternoon. I'm not completely sure I follow your question, and I may need you to submit a case so that I can understand it in more clarity. But what I think I'm hearing is you're on the measure progress page. You should be seeing different tabs for different types of actually, hold on one second. Let me just view progress tab, right?
Measure, view progress, you're right.
Yes, okay. And then what you're saying is you're only seeing information for the patients that you were consecutive?
Consecutively completed, yes.
Okay, yeah, so I do believe that's intended. I just would need to better understand, and I think that's probably better accomplished if we put it through the service center. And that would allow me time to review what you're seeing and have a more complete response for you.
Okay, got it. So that on this page, it gives me only the consecutive completed, didn't give us the what are the we completed, but not consecutive. But on the report data tab, you can use the drop down menu to select any measures, and gives you the completed, and also if we skip anybody, it will on the bar it shows like gray bars, and then green bars following that gray bars that we complete, and tells us who we are not completing.
Right, yeah, I think because I don't want to take up too much time, but I do truly want to understand what you're seeing and make sure that I answer correctly. It would just be helpful if this came through the service center.
Okay, thank you so much.
Thank you.
All right, thank you for that discussion. We do have a couple more questions that have come through the queue. The first question's for Jamie, asking for Prev 10 tobacco. If a patient is offered cessation medication to assist in quitting but refuses, does this count? Jamie?
Yep, thanks so much for this question. This does count. You attempted to provide cessation, and that meets the expectation of the measure if that patient was screened positive for tobacco use. Thanks so much.
Thank you. Our next question's for Deb in relation to DM2. And the question's asking, to clarify, does a documented diagnosis of prediabetes make a patient excluded from the measure denominator?
Okay, there's a couple of things I'm going to suggest here. First of all, I would definitely look at the coding document for the confirmation, the diagnosis codes that CMS has provided. In addition, the patient does need to have an active diagnosis of diabetes during the measurement period, or an active diagnosis of diabetes during the year prior to be included in the measure. However, also of note, the 2023 CMS Web Interface DM2 measure specification was updated to align with the intent of the measure, which is to ensure that the hemoglobin A1C control in all patients with any diagnosis of diabetes. Therefore, the guidance to include type 1 or type 2 diabetes was removed. So there's a couple of things going on with the DM2 measure, and what I would recommend is that you review your medical record documentation being used to confirm diagnosis of diabetes in conjunction with the coding document that's been provided to ensure that you are confirming based on the appropriate diagnosis. And the reason for this is you don't want to hold yourself accountable to the numerator quality action if in reality the diagnosis of diabetes isn't appropriate. Thank you.
All right, thanks, Deb. We have another question on the line from Amanda. Amanda, we have unmuted your line if you would like to unmute yourself.
Sure. Can you hear me okay?
Yep.
Awesome. Thank you. So it was a little confusing to put in the chat box, so I apologize. In web interface support call number 2, there was something brought up when I was reading the transcript that I didn't catch virtually and live. Something in reference to Prev 6, how they identified the lower age limit, needs to be 45 instead of 50. But my actual question is, how does that impact the sample? So I put in a support ticket and I got a response, which I appreciate. The need, for a lower age limit was determined through service center interactions with 2 ACOs, et cetera. And they said that there were the web interface application and any downloads of the Excel that happened after Monday, the 22nd, contain the corrected data. But my question is my ACOs were always sampled at 616 Prev 6s, like before, this was potentially discovered. So I don't understand the implication on our ACOs. Like, I can't have more than 616 and no patients are being skipped. So how are we impacted? And because I've most definitely been using the Excel from before the 22nd of January.
Your sample does not change.
Okay.
It's just that now you will be able to update those patients that were in that 45 to 50 age range that you would not have been able to update prior to the fix. Because they weren't falling into the right age range. So they're still in your sample and they're still accessible and you shouldn't really have to do anything. It was just that some people were noticing that the patients you weren't able to do anything with them because they had an age not confirmed in the Excel. And they weren't able to make the updates in the Excel because the Excel had that value and it wasn't a changeable value.
Oh, okay. So the patient, if I had any patients that were potentially impacted, it would have been in my sample already from the beginning. They would have been somewhere between rank 1 and 616. And then now potentially they're editable to select an appropriate response versus age not confirmed, but they're still in the sample. I need to answer it accordingly like I would have, except now I can change the response in the Excel, right?
That's correct, Amanda.
Okay.
Yes. And thanks for asking this question. It was good to clarify.
I appreciate it. Thank you.
All right, thank you, Amanda. We noticed that you had asked that question in the chat as well, so we went ahead and marked it as answered since you asked it over the phone too. Our next question is for Deb, and the question is asking for Prev 10, physician performed screening and documented that patient is not a tobacco smoker, but did not document not a tobacco user. Is this documentation sufficient as they did not specify smokeless tobacco in the note?
Thank you for this question. I am going to point you to page 35 of the FAQ just so you can go back and reference this as need be. The intent of the measure is to determine if the patient was screened for tobacco use at least once during the 2023 measurement period. Screening for tobacco use must occur during the encounter. Therefore, if a clinician has documented a status for any type of tobacco use, whether it's non-smoker, smokes, uses smokeless tobacco, that does meet the performance requirement for the screening component of the numerator. Thank you.
Thanks, Deb. Our next question is for Katie. For Prev 12, can you clarify a positive depression scoring threshold for the PHQ-9 screening tool?
Hello. So for Prev 12, the measure specification does not outline specific thresholds for positive or negative results for depression. That would be within this specific tool that you're using, since the measure allows for a number of different tools to be used. So we would suggest you refer to the tool to determine negative or positive, in addition to the patient's interaction with the clinician. Thank you.
All right, thanks, Katie. Next question is for Deb again. For Prev 7, Season 1 pre-populated answer, no vaccine received, and the Season 2 pre-populated answer, no qualifying encounter. Are we allowed to change the Season 1 no answer? And for the no answer qualifying encounter answer, then in fact do have encounters, we are not allowed to change these answers, how do we get credit for these?
So for the no vaccine received, if you have that and you find medical record documentation that the vaccine was received, you should absolutely change that. Or even if there's documentation of a denominator exception, you should change that no response. Because that patient has been sampled into that flu season. For the no encounter, you are not able to change that particular one because the patient wasn't included in your sample. So if you do change it, as Carrie has explained already, if you do change it, it will create a situation where you receive an error. It should not be changed. It is no different than CMS providing the guidance that you should not be including patients, and you can't include patients in other measures in which they have not been sampled. Thank you.
Thanks, Deb. Our next question's for Prince. We are finding a lot of patients in our sample for Prev 7 have had a flu shot before the 2023-2024 season between October and December of 2023. But the web interface is hard-coded with no encounter, so we're not able to attest to the patient receiving the flu shot this season. Does this mean that we will not get credit in the measure for patients falling into this category, even though there is clear medical record documentation of a flu shot? Why are we not able to attest?
Yeah, hi. So the CMS Web Interface sample uses Medicare administrative data, i.e. claims data, from January 1st, 2023 through October 31st of 2023. For the second flu encounter timeframe, only qualifying encounters that span from October 1st, 2023 to October 31st of 2023 are included in the sample. Therefore, qualifying encounters from November 1st, 2023 to December 31st of 2023 are not captured within the CMS Web Interface. However, ACOs are not penalized for patients listed as having no encounter. Thank you.
Thanks, Prince. Our next question is for Deb. Can you please repeat your answer regarding DM2 and using confirm the updates for prediabetes as a qualifying diagnosis?
Absolutely. What I actually referenced is going to the CMS Web Interface DM coding document, specifically the denominator codes tab, to be able to identify if your medical record documentation does support the denominator coding that would be considered diabetes diagnosis that would be eligible. I was able to open up that document myself. I am not finding any coding for pre-diabetes as confirmation of diabetes. So my response would be, if that is the only thing you're finding is pre-diabetes, that does not meet the requirements for confirmation for the DM2 measure. While DM2 is not specific any longer to type 1 or type 2, there are other specified diabetes coding included. It does not include pre-diabetes. Thank you.
Thanks, Deb. We have another question for you, this time about Prev 10, and the question reads, the answer given about Prev 10 was if you screen for any tobacco use, you met the measure. However, does that mean that I only have to ask, do they smoke, but not their smokeless use, and it will meet the measure?
So first of all, let me clarify that it's not that it meets the measure, it just meets the screening component of the measure. And yes, the measure is, really all tobacco use. However, if what you are finding in medical record documentation is specific to, patient is not a smoker, patient is not a smokeless tobacco user, is a smokeless tobacco user, you can use that information for the screening component of the measure. You do not have to have documentation that you have asked the question of all of the different types of tobacco use. The thing to think about is the measure is tobacco use in general, mainly because if say I'm a tobacco user and it happens to be vaping, and my clinician is concerned about tobacco use and they just ask me if I'm a smoker, I may say no. But I'm a vapor, and that would be information that would be relevant to my healthcare. However, the specification itself, as long as there is documentation that that screening has occurred for tobacco use, the measure does not require that you have documentation for every type of tobacco that could be screened. I hope that makes sense. If it doesn't, and you want to ask the question, rephrase it or raise your hand, we can try and answer it in a different way, or you are certainly welcome to open up a ServiceNow help desk case and we will address it in that avenue as well. Thank you.
Thanks, Deb. Just another reminder that you can submit your questions via the Q&A box, or you can raise your hand and we will unmute your line so that you can ask your question live over the phone. Moving along, we have another question regarding Prev 10, this time for Jamie. Jamie, the question's asking, for Prev 10 tobacco, if a patient declines smoking cessation, does this count?
Hi, this is Jamie. Thanks so much for this question. I'll be honest, I've been sitting here thinking this one through, trying to determine the best response. So I think this question's a little bit different than the prior question in regards to pharmacotherapy being declined, because that was a specific interaction for tobacco cessation. And so it was easier to provide that yes or no response. But for this particular question, it could be a little more nuanced and we would want a little more information. I'm not sure, based on how this question is framed, if it's decline smoking cessation, decline pharmacotherapy. So that's why I really can't give a yes, no for this particular question. I would want to have a little more information. And please, I'm very curious about this situation and scenario within the medical record. Submit this as a ServiceNow help desk ticket and we can get to the bottom and give you the most appropriate response for this particular scenario. Thanks so much for this question.
Thanks, Jamie. All right, it looks like we have a question from Amber on the line. Amber, we have unmuted your line if you would like to unmute yourself. Amber, are you there? Oh, Amber, I see you did not mean to raise your hand. All right, so just a final call for questions before we wrap up. If you do have a question you'd like us to answer out loud, please feel free to put it in the chat, or you can raise your hand now and we will answer your question over the phone. All right, seeing no further questions coming through, that will conclude our Q&A portion of the webinar. So I'll turn it back over to Sandra Adams-Slaughter to conclude the call. Sandra?
Thank you, Haley. Thank you all for joining us today. As a reminder, the slide deck, recording, and transcript from today's call will be available on the QPP webinar library in the next 2 weeks. The last CMS Web Interface support call will occur on March 6, 2024, and will cover frequently asked measure questions related to CARE 2 and MH1. Thank you.